Hello, this is a virtual pathology specimen of a fistula-in-ano, and what we are looking at here is the cut surface where we can actually see the fistula tract. And rotating the specimen, this is actually the skin surface. So here is the external opening of the fistula. So this means that this end is the internal opening which opens into the anal canal. Let's look more closely at the fistula tract. It is quite a well-formed tract, and we can see some blackish areas of hemorrhage here. Sometimes there can also be whitish areas of fibrosis, but we don't see this here. And in this specimen, we also don't see the sphincter muscle. Let's learn a bit more about fistula-in-ano. Fistula-in-ano is an epithelial-lined tract, and this runs between the internal opening of the anal canal, the mucosa, to the perianal skin, where there is the external opening. And this is what we saw in this case. Sometimes the tract is more like a sinus tract, where it is blind ending within the perianal soft tissue. Fistula-in-ano is classified according to the relation to the internal and external sphincters. So, for example, they can be suprasphincteric, intersphincteric, etc. It tends to occur more frequently in males with a mean age of about 40 years, and some of the risk factors include presence of prior anal abscess, and this usually occurs because of infected anal glands, pre-existing conditions such as inflammatory bowel disease, in particular Crohn's disease, and in this instance we may actually see granulomas microscopically, infections, for example TB, and history of pelvic radiation. Clinically, there may be some pain on defecation or itching, and sometimes discharge with blood or purulent material or even potentially fecal material. The treatment is generally fistulotomy, where there is an incision made along the tract and the tract is laid open to heal. There is, however, a higher risk of recurrence in some clinical scenarios, for example, fistulae that occur high up, such as suprasphincteric fistulae, when there are multiple fistula tracts, and also in the background of inflammatory bowel disease or infection. Grossly, the tissue may be received piecemeal, so sometimes it can be difficult to appreciate the tract in the gross specimen. However, in intact specimens, we can usually see this tract. This one has some hemorrhage and also areas of this whitish fibrosis within the wall. Microscopically, we can see that there is a tract leading downwards from the overlying epithelium. And often the tract loses its epithelial lining and what remains is inflamed granulation tissue. There can be acute and chronic inflammation and sometimes abscess formation. And occasionally we can also see many histiocytes and even foreign body type giant cells. Granulomas should be looked for, and if present, then stains for fungal organisms as well as acid-fast bacilli should be performed. And also there may be a potential underlying cause, for example, Crohn's disease. On higher magnification, this is the area of the mucosal opening, and we can see that there are these small blood vessels with lots of edema and inflammation around them. So this is inflamed granulation tissue. And deeper down into the tract, again, we see lots of blood vessels. We don't actually see a residual mucosal lining. And we see mixed inflammation. There's lots of acute inflammation here, but we also see some chronic inflammation in the form of plasma cells. In this particular case, we do not see granulomas. The fully interactive virtual pathology specimen, as well as annotated gross and microscopy pictures, can be found in our free online pathology resource, Pathweb. Registration is free and the link is in the video description. In summary, this is an example of a virtual specimen of fistula-in-ano, and here we can see the fistula tract that extends from the internal opening of the anal mucosa laterally and downwards into the perianal skin. Some predisposing conditions will include inflammatory bowel disease and infections. Thank you.